Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
Hi, I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
This patient has squamous cell cancer, lung cancer, and this is a 73-year-old reformed smoker with a 40 package of tobacco smoking, had malignant pleural effusion, received 4 cycles of paclitaxel carboplatin radiation therapy, and then had progressive disease. So looking at the details, this patient presented with nausea, decreased appetite, and pain over the left chest with intractable non-productive cough, and had a past medical history of diabetes, hypertension, with a 40 package of tobacco smoking, but quit 20 years ago with no history of drug or alcohol abuse, and has been an Army veteran, served in Vietnam, and with no family history of lung cancer. Back in 2017, had a squamous cell cancer of the left distal mainstem bronchus. As you can imagine, the EGFR negative, ALK-FISH negative, and ROS was also negative, but the PD-L1 was 40% positive, had stage 3A disease, attempted left pneumonectomy, but was abandoned because of involvement of the great vessels, and was found to have pleural effusion very soon and demonstrated to have malignant cells and received chemotherapy, paclitaxel, carboplatin. And then 4 months later, showed left hilar mass with symptoms with cough and shortness of breath, received radiation therapy, 37 gray in 15 fractions, concurrent with paclitaxel carboplatin with improvement of the symptoms, and then got maintenance nivolumab for 5 cycles and had a CT scan back in November 2018. And before we review the CT scan, a cell-free DNA revealed PA3 kinase mutation with amplification and P53 mutation. So let's review the films from November of 2018. Dr. Ginsberg, please.
These images demonstrate left supraclavicular adenopathy, as seen on the left-hand image with a red arrow. There's also a further adenopathy in the upper paratracheal region, but not included on these images. Additionally, we see that on the middle images, there is consolidation and lung, probably some volume loss with lung collapse in the left upper lobe. Some of this is a combination of post-radiation treatment changes and atelectasis. And on the last image, we see a hepatic metastasis, which measures 5.2 centimeters in the lateral segment of the left hepatic lobe.
Thank you. You know, this is unfortunately a medical issue, and the problem is one of progressive disease following platinum, carboplatin, paclitaxel, and nivolumab in a patient with metastatic squamous cell cancer. Unfortunately, all too common scenario. Dr. Stinchcomb, how would you manage this patient?
Thank you, Dr. Govindan. And I think that this is one of the more difficult scenarios that we have within medical oncology. With such high hopes on immunotherapy, and when it doesn't work, I think we're somewhat have a limited number of options. We would normally look for a clinical trial for this patient to see if he's eligible for a novel therapy. I think we all recognize that sometimes it's been hard to get people on clinical trials, and so that they're not always available. I think the standard therapy would be docetaxel alone or with ramucirumab. The addition of ramucirumab does improve response, progression-free survival, overall survival, albeit modestly, and comes with some additional toxicity that needs to be considered. And then sometimes I will use single-agent chemotherapy, such as single-agent gemcitabine at this point. I think there's really limited evidence for what the optimal therapy is in the third line setting these days. And so it's a very challenging disease setting. It's, I think the therapy is not standardized at this point.
You know, again, we can take a little bit of a deep time to discuss some of the issues that we confront in practice. So let's start with docetaxel. What dose do you use?
So I generally discuss two schedules. Every 3 weeks, I found the 75 milligrams per meter squared very poorly tolerated with an impact on the patient's quality of life due to the toxicity. So most of the times when I use the every 3 week schedule, I'll use 60 milligrams IV 3 weeks. I think for the older or frailer patient or borderline performance status, I've also used the weekly dosing of 30 milligrams days 1, 8, 15, the Q28 day schedule. Because I feel like if I run into difficulties or toxicities, I can hold a day 8 or 15 and have a little bit more control over the therapy.
Yeah, I do the same thing. In fact, the 60 milligram per meter square, even though that has not been the dose used in some of the seminal studies, it is much better tolerated in our patients. And any cautionary note for our practicing physicians when they decide to use ramucirumab with docetaxel?
I think the concern with ramucirumab is that there can be some increased stomatitis. There can be some increased proteinuria and hypertension, which are somewhat manageable. But there also can be some increased risk of coughing up blood or GI bleeding, which can be sometimes sudden and emergent. And so I think that's the real caution. And I think when I really think about ramucirumab, I really think about it in the context of the benefit, which is relatively modest. And so I tend to use the docetaxel ramucirumab in my really pure 0 to 1 patients with a minimal comorbidities, where I think they can incur the additional toxicity without a big impact on their quality of life.
Yeah, I also worry about patients who have a large tumor next to a big blood vessel. So those patients, I try to avoid those patients. And much like the concerns we had with bevacizumab, with massive bleeding eroding into the blood vessels, and I do avoid them. What do you think about that?
I think I triage it based on a history of hemoptysis, location, and I think we both sort of practice that the bar to use ramucirumab has to be relatively high because the risk associated with it, and I think it's really only used in selective circumstances in my practice.
A question comes up now and then. If somebody progresses on nivolumab, is it worth trying other agents like pembrolizumab or tislelizumab in this setting? After all, they're approved for those in second-line setting, although not for those who progressed on another checkpoint inhibitor.
This is actually a very common question, I think, from patients and families, I think probably because the television ads are so ubiquitous. But I generally tell the patients that if you progress on one PD-1 or PD-L1 inhibitor, there's not a lot of value to converting to a different drug within the same class. And I've also had the question just recently of, can you give me Opdivo and Yervoy or nivolumab, ipilimumab are the generic names. And I think if you really look, adding a double agent immunotherapy after failure, single agent immunotherapy really has not gotten us much benefit or activity. So I generally say that I would not recommend switching, nor would I recommend doing the double agent immunotherapy.
Yeah, I agree with all the points you raised. And I think in terms of research, there are some interesting approaches being pursued using various different agents, including pegylated IL-2 and using different checkpoint inhibitors targeting LAG-3, TIM-3, and other agents. But I think these are all highly investigational at the present time. And I'm hoping that the current crop of clinical trials will tell us where to take the next advance in therapy here, but it is a bit of a challenge. I also want to quickly remind people that those with excellent performance status should be considered for some of these clinical trials, including some cellular therapy trials. Anecdotally, we have seen some nice responses in patients with squamous cell lung cancer, so it's certainly worth considering those cellular therapy trials as well. Any comments from the radiation perspective, Dr. Kester?
Well, it certainly seems like a reasonable consideration to give palliative radiation treatment like they did in this particular instance. It was obviously with the malignant pleural effusion to begin with. This was, an This was a more of a distant problem. And, you know, we would only do the radiation treatment in a palliative manner, typically in that situation, unless it had been a very long disease-free interval. So the regimen that they chose, 37.5 gray and 15 fractions, that's reasonable. You could do as low as probably 30 gray and 10 fractions, or as much as 50 gray and 25 fractions, you know, depending on all of the surrounding clinical circumstances. Now, unfortunately, there is nodal disease as well as hepatic metastasis. And I think the primary treatment in this situation is systemic therapy. Radiation treatment will be used only if needed for palliation or problems that need local correction.
Thank you. Dr. Force, any thoughts?
Not really. I mean, you know, it's hard to know, you know, again, why the patient was initially unresectable. You know, that said involvement of the great vessels. So, you know, I would assume that means the aorta, given where the mass was. You know, obviously, if you can resect, and we can go to kind of great lengths, even reconstructing the pulmonary artery if we need to. This is kind of why you want to try to resect when you can, because sometimes it becomes hard to manage these patients when, you know, the big mass or bulk of the tumor is left in there. So no other comments from me though, other than that.
Thank you. Excellent discussion. So to summarize, this is the issue of managing a patient with squamous cell metastatic non-small cell lung cancer who has progressed following paclitaxel, carboplatin, and nivolumab. The key takeaway points are: one, standard therapy is docetaxel with or without ramucirumab. We would consider giving ramucirumab along with docetaxel for patients with good performance status who meet the eligibility criteria for the study that define the role of this combination. Most importantly, no significant bleeding and no vascular involvement and large mass, etc., near the big vessels. Second practical point is docetaxel doses 60 to 75 milligram per meter square every 3 weeks. 60 milligram per meter square is fairly well tolerated, or even a weekly consideration at the dose of 30 milligram per meter square on day 1 and 8, 15, on day 28, repeated every 28-day cycle, I think is reasonable. We don't really see a big benefit in changing from one PD-1, PD-L1 inhibitor to another in a situation like that. And we also see there is no benefit for giving the combination of nivolumab and ipilimumab in this setting. And we should consider these patients potentially for clinical trials.